Hello. All right, it's 2 o'clock, so we'll get started. Welcome, everyone. Thank you for joining us today. My name is Mara Quidis. I'm the Education Coordinator with the Finger Lakes Caregiver Institute at Lifespan, and I'm also your host for today's program, FTD 101. And I'd like to welcome you on behalf of Lifespan. I'm going to take a brief moment to tell you about Lifespan and then go over some housekeeping before turning it over to today's presenter, Sue Craine. Next slide.
Oh, there we go.
Thanks. Lifespan is a regional nonprofit organization dedicated to helping older adults and caregivers take on the challenges and opportunities of longer life. We provide information, support, and guidance through more than 30 services. All of our services are provided in Monroe County, and some are provided in outlying Finger Lakes counties and across New York State. If you have an aging or caregiving issue, call Lifespan. We're here to help. Next slide. Today's presentation is a part of our Caregiver Education and Wellness webinar series, sponsored by the Finger Lakes Caregiver Institute at Lifespan, funded by a grant from the New York State Department of Health. We're offering these Caregiver Education and Wellness webinars almost weekly, and next week our topic is Healthy Living for Your Brain and Body, presented by our partners at the Alzheimer's Association. For information on that and for other events and programming coming up, please visit our website at www.lifespanrochester.org. Before we begin, a few quick housekeeping items. As you might see on the screen, it'll show that this session is being recorded. We have it set up so just myself and Sue will be shown in the screen. And then we put these on our website for people to access. So if you have anyone you want to share it with, you can do so later. All attendees will be in listen-only mode. If you have a question or comment during the presentation, please use the chat window. The presenter will address some questions midway in today's presentation, and then she'll jump back into presenting and take more questions at the end. If anyone wants to see our presenter in larger view, you can find the 3 dots next to her name and then click on pin video. And so Sue's icon will be a little bit bigger if right now all you're seeing is a really big PowerPoint. So now let's welcome today's presenter, Sue Craine. She's a licensed Master of Social Work, Master of Public Administration, and is a care manager and educator with the Finger Lakes Caregiver Institute at Lifespan. Thank you, Sue, for being here today, and I'll let you take it from here.
Thanks, Mara. So yes, I am going to be addressing what is known as FTD, which is called Frontotemporal Dementia or Frontotemporal Degeneration. I feel that I've seen both terminologies used in many different aspects of the medical profession and some other areas. So just a quick agenda. We're going to do, I'm going to talk very briefly about dementia overall. I'm going to talk about the different types of frontotemporal dementia, and I'm going to use frontotemporal dementia throughout my presentation, or FTD, which is the acronym typically used. I'll talk a little bit about how it's diagnosed. I will be talking about children, how addressing FTD with children might be important because of when typically this dementia emerges in people. Children sometimes are affected by this a little bit more than maybe some other dementias. And then I'll talk a little bit, I titled it as management of FTD, but basically it's talking about how caregivers can help people with FTD kind of live the best life that they can. So a little bit about, you know, my, sorry, the slide went in advance. So I'll talk a little bit about my professional background and what my current role is. So as Mara mentioned, I'm a licensed master social worker. I was licensed in 2020 of January 2020 of this year. I had my MSW as well as a master's in public administration and an undergraduate degree in communications. I've worked in nonprofit all of my career. I spent 10 years being a consumer environmental advocate for a New York statewide organization. And then I worked for 12 years with a nonprofit in New York City that did volunteer management, and at that organization, I actually managed a team ranging from 8 to 12 people. I did a lot of ongoing programming and disaster responses, and I worked with a multitude of different populations, including older adults. My current role has me as a care manager and an educator with Finger Lakes Caregiver Institute, which is a program at Lifespan that's in partner with the Alzheimer's Association of the Finger Lakes region. What's a little bit unique about my role is that I am connected to the Rochester Regional Memory Center. I work very closely with the neurologists about connecting their patients' caregivers with support and kind of getting to know the caregivers, families, friends, as well as the patients as they kind of try to navigate the diagnosis that they have. So what is dementia? Dementia is an umbrella term. It's actually used to define over 100 different conditions that can impair memory, behavior, and thinking. So dementia is a pretty broad term. And as you can see here, it's very often referred to as an umbrella. And you can also see on the screen the 4 different more common types of dementia that might be diagnosed. Alzheimer's is usually the one most people are familiar with. And then some other more common ones are frontotemporal, like I'm speaking about today, vascular, Parkinson's, Lewy body. It is possible for a person to have a dual diagnosis of Alzheimer's and vascular dementia, of frontotemporal dementia and a form of Parkinsonism. So that's just something to be aware of. It is possible to have more than one dementia diagnosis. And I am going to be focusing on frontotemporal. As you can see here, it's a pretty small piece of the dementia pie. Alzheimer's is the largest. And the thing about frontotemporal, it's mostly a disease that affects behavior and language, some motor skills as well. It's also one of the most common onset dementias that onset between the ages of 45 and 60. So even though it's a small piece of the dementia pie, it is the one that hits younger people the most, which I can tell you from experience of working with clients that if they're in their 40s or their 50s and they get diagnosed with this, it's a huge blow. It's not something many people have heard of. And sorry, there's some feedback there. And it's just something that takes a lot of people by surprise. So this is a chart kind of doing a comparison between FTD and Alzheimer's. As you can see, average onset is between the 50s and 60s. It hits between 50,000 and 60,000 people yearly versus almost 6 million people for Alzheimer's. Memory loss is kind of the hallmark of Alzheimer's, where FTD, it's behavior, language, and movement. The inherited thing, I will talk a little bit about genetics and around FTD. There are some genetic markers that seem to be correlated with developing FTD, but I want to be very clear and careful. Just because someone may have a genetic marker does not mean they're going to develop FTD. It's just something that scientists have found to be common, but doesn't seem to have a direct cause and effect. The other thing about FTD is it does take typically longer than average when compared to like Alzheimer's to actually diagnose. Very often there are periods of time before the person receives a diagnosis of FTD where they're diagnosed with many other different types of diseases, and it does take a while for doctors usually to figure out and give a pretty definitive diagnosis. So FTD is a complex group of overlapping disorders. So as you see here, there's a wide range of symptoms and expressions of them. There are multiple, it's called pathologies. One thing I am going to say is the reason I'm pausing midway in the presentation is there's going to be a lot of jargon in this. I think it's something that is important for people to hear, because medical professionals are probably going to use this if you're working or you have someone in your life who has FTD. And I think it's important to maybe hear the jargon and then maybe see some of the more common language things to describe it, so that if you hear a doctor mention it, you're like, oh, I've heard that before. I think it's this, you know, and can kind of give you some additional knowledge. So the one thing about dementia is it usually means that in a person's brain, these particular proteins are building up in places where they shouldn't be, and it's affecting the makeup of the brain. It can cause degeneration of the brain. And with FTD, it's usually what they see is a buildup of tau proteins is probably the most common. That one is common in pretty much all dementias. And then with FTD, they've actually narrowed down a few additional proteins, the TDP43 and the FUS. And then the genetics that I mentioned briefly before, the MAPT, the GRN, and that C9ORF72, like I said, a lot of jargon. It just means that they've found those are the genetic markers they have found of the people who have agreed to go through genetic counseling. That's the other part, is the percentage of people who actually go through the genetic counseling versus the total amount of people who may have FTD is, you know, pretty vastly different. So that's just, you know, something to kind of be aware of. FTD has variable rates of progression, and each person's experience with FTD is unique to how that person is as an individual. So basically the phrase I like to use, if you met someone with FTD, you've met one person at FTD. You can't really bunch them into groups or anything like that. So FTD, excuse me, let's see if I can get this slide to advance. Sorry, my internet, I think in this room is being a little funny. So like I said before, FTD and dementia, that means there's changes in the brain that are going on, and FTD affects specifically the frontal lobes of the brain and the temporal lobes of the brain. So the frontal lobes are actually located like right above the eyes and right behind the forehead. I can't actually do it on the screen, but the general idea. And this is the area that directs executive functioning. So it's planning, it's sequencing, prioritizing, multitasking, correcting errors. It's also the area that manages emotional responses and where people store the information about social behaviors and what's inappropriate in certain social behaviors. So a good example is shouting in a library or at a funeral. It's the area that helps a person link words to form sentences. And there are some motor functions such as moving arms, legs, and mouth that are located in the frontal lobes. The temporal lobes are actually also close to the frontal. They also have a memory component to them, and they have language. They give the person the ability to understand words, how to speak, how to write, and how to connect words and the meaning of the words. And it helps the person recognize objects, and then also is the area where a person stores emotions and to certain objects or events. So basically, if you look at a picture of your grandmother and she's someone who had a positive feeling in your life, when you look at that picture, you may feel love for her, you may feel sadness if she's passed. So it's kind of like where that type of function is stored in the brain. So I'm going to cover the three bigger buckets of frontotemporal dementia. I'm going to talk a little bit about some of the subtypes you might see. The first big bucket is ones that indicate a progressive behavior or personality decline. So some diagnostic terms you may heard is behavioral variant frontotemporal dementia, or BVFTD, temporal frontal variant FTD, TVFTD, FVFTD, and Pick's disease. And And those all are talking about someone's behavior or personality changing. And some early symptoms are apathy, reduced initiative to do things, that inappropriate behavior in social situations, or impulsive behavior. So very often I do hear of people with FTD like running up balances on credit cards, and their caregivers didn't know they were doing that. But the one thing is memory does seem to be generally intact. So they can remember doing it. They can remember purchasing all those things on the credit card, but they don't see the inappropriateness of, maxing out your credit card. So that's kind of the progressive behavior and personality decline bucket. The next one is progressive language decline. So some diagnostic terms for that one is primary progressive aphasia, progressive non-fluent aphasia, and semantic dementia. That is hallmarked by early symptoms of a person can't understand words or recognize familiar people and objects. That is typically seen with the semantic PPA or semantic dementia. Another symptom is a person is omitting words that link nouns together. So that can include the word to, the word from, and the actual word the. That is typically seen with agrammatic PPA or progressive non-fluent aphasia. And then the last subtype of trouble finding the right words while speaking. There's a typo on that slide, excuse me. And there's hesitation and pauses in speech. And that's typically seen with logophonic PPA. And then the last subtype is the progressive motor dementia. And that has a couple of specifics. So there is corticerebral syndrome, and you'll see that a person has muscle rigidity. They have difficulty closing buttons on clothing, operating simple appliances. They have difficulty swallowing, and sometimes there's language or spatial orientation problems. There is progressive supranuclear palsy, and that progressive issues with balance and walking, slow movement, falling, body stiffness, restricted eye movements. I actually been working with a client for the past year. Her husband has PSP, and the thing that was happening pretty quickly was his sense of balance and walking declined pretty rapidly, to the point where he did need first a walker, then a wheelchair, and then unfortunately he became bedridden. But the other part of it is because because of the FTD, he really did not have a sense that there was something wrong, and he would continuously try to get himself up out of bed and would have a lot of falls. So that's something I've seen pretty recently. The other two are FTD with Parkinsonism. So that is someone who has movement problems similar to Parkinsonism, and they have slow movement and stiffness and changes in behavior or language. And then the last one is FTD with, forgive me, I'm going to butcher this. It's amyotrophic lateral sclerosis, or FTD-ALS. That is someone who has changes in behavior and language. They have muscle weakness and loss. They have fine jerks. They're wiggling in muscles. It's a combination of FTD and Lou Gehrig's disease. So this is why I think very often a person may not receive an FTD diagnosis for a while, because you can see a lot of these subtypes has something else going on in it. So I have seen a lot of people start out with a diagnosis of Parkinsonism or ALS, and then once it becomes clear that it's not just the movement issue, there's also a behavioral or maybe a language issue, then the neurologist may look again and say, oh, you know what, it's not just Parkinsonism, or it's FTD with Parkinsonism, or it's FTD with ALS. And that's kind of something that happens. So I've throwing out a lot of jargon. This is the point where I wanted to pause and see if anybody had any specific questions to what I've covered so far. I don't know if there's anything, Mara, that popped up in the chat.
So we have one, are there any FTD support groups for caregivers, online or otherwise?
I am going to talk a little bit about one big organization at the end, towards the end, where I actually got the bulk of my information. It's the Association for Frontotemporal Dementia. And they do run some support programs. And I believe they are trying to run a few things online. You know, in the world of COVID, things got switched around. And I know that they have been trying to do some online stuff, but I don't know where they are at this point. But at the end, you'll see a couple of resources, and you'll be able to look online to see if there's anything available for you. I will say, I think the Rochester Regional folks are planning to do something for FTD specific people in the fall, but I don't quite know how that's going to look. The neurologist is planning to run a series for their patients, and I'm not sure what their plan specifically is for a support group, but I think that might be coming.
Okay.
Any other?
Thank you. Yeah, so we have another, could you talk more about PPA behaviors?
Let me go back to that one. So with PPA, the thing about it is it's actually a little hard to tell because the person is losing like those little joiner words. So that's one of the other reasons why I think it might be hard to diagnose, because those joiner words, people like, they don't necessarily always hear them when you're listening to somebody speak. So it can take a while before you realize like, oh, dad never says and, or he never says to, like it always gets skipped. Like, what is that? Yeah, the language decline part is usually what takes a while to emerge. And it really has to become very, very evident before someone will either the people in their lives will say like, there's something going on, you're not saying this word ever, or they mix up words. So, you know, instead of saying pen, they might say cat consistently, like, and it's so unique. That's the thing, is it's not like people with PPA, if they lose the word pen, they are going to automatically substitute it for the word cat. They're going to substitute it with something that is unique to them. So that's why I think people do struggle a little bit with the diagnosis part, because like I said, there's no bucket that like, oh, if that person starts using this word for this object, something's wrong and we need to have it like looked at. I'm trying to think if I've had any clients specifically with PPA recently. I have not recently. There is one gentleman who I think does have a form of it, but his language deficits are not very obvious, and he really is good at masking it in front of people outside of his immediate care circle. So whenever I see them, that's the thing, is the other part is that if the person realizes that there is something wrong, they will do unintentionally, they're not trying to like be, you know, non-cooperative. It's that they're trying to not show the public like something's wrong with them, which is, I think, a natural response, so that their caregivers may notice something. But, you know, if I met with them across the table, I might never know. And that is definitely something I hear from caregivers for people with FTD, and particularly since very often their physical health is actually pretty good, that you won't necessarily know something's wrong if you only talk to them for a very short period of time. And that's why I'll talk a little bit about the diagnostic process and why it's important that caregivers are actually involved in the diagnostic process. And
so it can be a little more subtle, so it can be really important for caregivers to know what's happening and more details.
Yeah, it's really, really important. I'll talk a little bit about that more further down the line. did another question pop
Yeah,
up?
we have one more question.
Okay.
Can you talk a little bit more about the connection between dementia/FTD and Parkinson's?
So that the way it's been discussed to me is that very often the physical motor problem emerges first. So for that, for example, for the person the client I talked about who has PSP, they originally thought he had Parkinsonism. And that's because his motor functions, like his physical balance stuff, started to emerge way before anything else did. So the physicians actually noticed that first and said, okay, he has Parkinsonism. And I believe they described it as like a mild case in the beginning, but then as it progressed, I believe, and once again, this is the unique thing about FTD, is that it's very, very individualistic. He progressed in terms of his Parkinsonism pretty quickly in terms of balance and walking. He declined much quicker than I think they thought would normally happen for somebody with Parkinsonism. And then the language stuff and then also emerged at the same time. And that's when his wife was like, this doesn't seem right. Like, for everything because she had some experience in the medical field, and she said that she noticed the language thing emerging, and that is not something she had ever seen with Parkinsonism. So she actually kind of advocated with the doctors about having maybe some other testing or like a review be done, because she was just like, this doesn't match up with what I know, and I'm not sure if this is the right diagnosis.
Can you just ever listen to something? I could.
Okay. So I think we're going to move on, since I still have a bunch of stuff to go through, and then we'll have more questions at the end.
All right, sounds good. I'll disappear again.
Okay. So let's talk a little bit about diagnosis. So like I've been mentioning, diagnosis for FTD is determined by medical history and examination. So there is no specific test. There's no blood test.
Worn it in a long time.
There's no, there's no like one test a person can take and then they get a diagnosis of FTD. Very often it's a combination of a neurologist getting someone's history. That is very often why a neurologist, particularly I'm only going to speak for the neurologist at RGH. They actually don't want to meet with a patient unless someone else is with them, because they know the history, and getting the history of how things were prior to a person noticing problems is really important for diagnosis. And then they work with the neuropsychologists that are also in the office, that those two together will do a bunch of memory testing. They will do some motor testing. They do a whole bunch of things together to kind of try to come to a diagnosis. And then the final piece of it tends to be brain imaging, usually an MRI or a PET scan. And that's usually where they can see if the brain has undergone some changes. If they can compare it to a previous MRI or PET scan, that's usually the best scenario, but that doesn't always happen. So then they'll compare it to like a standard brain scan of that's in the age range of that person. So like I've been saying, it is pretty hard to diagnose. It takes almost 3 years typically. And like I've said, it's also often mistaken for other diseases, depression, particularly in the behavior, because I'm talking about like apathy and lack of interest. So depression often is one of the diagnoses that comes up. Parkinsonism is definitely one that comes up. And sometimes it's even, seen as being a normal aging process. And it usually comes down to sometimes the patient and their caregivers having to be, pretty, maybe sometimes aggressive with asking for additional testing. I actually had a client just tell me that she didn't realize she needed to ask for a memory doctor to actually review her mom's medical chart and kind of do some additional testing. And she was someone who's been a nurse for 30 years. So being an advocate for either yourself, if you think that you have an issue with your memory, or a caregiver, then, you know, sometimes you do need to be kind of a little forceful with medical professionals and say, no, I really think something is wrong. I do need to have some additional testing. And the thing, though, is that it's not definitive whether a person has FTD and many other types of dementia until the person actually dies and there's an autopsy. I know there's been some recent news stories about a blood test for Alzheimer's. That is the only potential like blood test I've heard of for dementia in a number of years, and I'm not quite sure where it stands in terms of, you know, how far along it is. So I'm going to move on to talking about how an FTD diagnosis can impact a family. So, you know, since FTD tends to get diagnosed in people younger, they often are at the peak of their working career. And they may still have younger children, maybe young adult children, teenagers, maybe even younger ones in the home. So that has, you know, this diagnosis has a way of really upending a family's life. There's economic consequences. There are, you know, relationships that radically change because you know, the caring parent may not be there anymore. And there is unfortunately limited in terms of treatment. It's not like there's a medication a person can take to stop the progression of FTD. Very often with clients, I talk about this concept of ambiguous loss. So, you know, caregivers do need to give themselves time to experience grief related to the fact that the person, whether it's mom, aunt, partner, is still physically robust. They may be, you know, still very physically well, but their behavior has radically changed. Maybe they do have some motor function issues, and it's vastly changed their relationship. So it's kind of an odd feeling to be mourning someone who is still there in some capacity, but, you know, learning to mourn and grieve that loss is important, because those who do not, I mean, this is just me from my personal experience with working with clients, the ones that have the hardest time tend to be the ones who are unable to, you know, kind of mourn the loss of their partner not being the person that they were when they got married, but they're still in this situation where the person's still there and they have to take care of them, and, you know, it's vastly changed the relationship. So I do think it's important to talk about ambiguous loss when dealing with clients who have some type of dementia. And then I did want to talk briefly about talking to kids about FTD, because of the fact that it is possible that younger children are still in the home. So I think if you're a parent or an aunt or uncle, or you're around kids quite a bit, I would agree with this, like young ones, children, even the littlest ones, will pick up when there are changes in the house and the family unit. And that's why it's important to maybe talk about, you know, the diagnosis and FTD, because if you are not the source of accurate information, kids are going to fill in the blanks with their imagination and may end up missing important information, and, you know, wondering if the behavior of grandma or mom or dad is because of something they did, versus a physical disease. So some recommended tips is talking in a straightforward manner, communicating at a level that's appropriate for the child in terms of age and development level, you know, being cognizant of the kid's reaction during the discussion and slowing down or repeating something if the child becomes confused or looks upset. And I think it's important to provide details if the kids ask, but, you know, don't force the kid to hear or manage information. I usually tell clients with children, but I think with, you know, not just young children, but even like older children and adult children, I often will tell, you know, the primary caregiver, you are going to just have a short conversation in the beginning where maybe you talk about the specific diagnosis, what's its name, what does that mean, and, you know, how this explains how the behavior has changed, and let them kind of absorb that information. It tends to be a lot, particularly if they're not involved very much in like the diagnostic process. So, you know, these conversations do usually tend to happen multiple times. I think it's always important to tell kids the truth. I think it's really important to say that you may not know the answer to something. And I think it's very important to let the kids know that it's, you know, this is this is a sad thing. This is, you know, I'm really mad at that this happened to us, and just kind of normalizing some of these feelings to help kids cope with the changes they may be seeing in the loved one with FTD. So I'm going to move on. There is a book called What About the Kids that is produced by the Association for Frontotemporal Degeneration. I found that book particularly good for helping caregivers talk to teens and younger children about an FTD diagnosis. It actually further breaks it down into the various age ranges and how to maybe address it specifically for that age or developmental range, so that it gives you some better, you know, more particular talking points. So this section is called disease management, but the best way to think about it is these are some things that to be aware of when a person has FTD as a caregiver, and some of the tactics you can choose to use when you're trying to support the person with FTD. One very unique thing is individuals with FTD lack an awareness of their own disease. It's actually a symptom called anogenesia, and I don't think I'm saying that right. But basically, they don't have any awareness about their disease. So I will give you a specific example. I have a client whose uncle has an aphasia. I don't remember which one. He's 90. He was driving consistently still, but was often getting lost, and he had like a couple of minor accidents. So he asked me as the social worker and kind of the representative as the neurologist office to go and talk to his uncle about stopping driving. And I basically spent over an hour talking to this gentleman about his driving, and at no point was he able to say, I have a disease or there's something wrong with my brain. I have seen patients that have different dementias be able to say that statement, like, I know there's something wrong with my brain. People with FTD tend not to ever be able to say that. They don't understand, or they're not able to have that type of awareness. I do advocate that just as as I said earlier, if you met one person with FTD, you've met one person with FTD. So care plans that involve physicians and other caregivers has to be very tailored to that person. And it usually, when it's that personalized and tailored, that caregivers usually have the most effectiveness with making sure that their individual FTD stays safe and they're able to live, as best as they can. If you ever see someone with FTD have a huge shift in behaviors, it's always important to rule out physical illness first, such as infection, or if there's a problem with seeing, hearing, sleeping, or they have some type of pain. So if you are caring for someone with FTD and all of a sudden they are very resistant to things that typically they were okay with doing, like dressing, like changing clothes consistently or bathing, it's definitely important to rule out physical illness first before talking about maybe there's been a progression in the behavior part of the disease. So some communication strategies. So it's important to acknowledge the emotions the person with FTD is displaying. You know, if they're very angry and frustrated, I think it's important to say, like, you seem very angry and frustrated. You know, can you tell me what is really making you upset? And I would highly, you know, suggest not trying to reason or argue or change their feelings. I think, you know, it's important to employ respectful communication. So even though you're in this role of a caregiver, most likely you're caring for somebody who's still an adult in many ways. And, you know, trying to tell the person you can't feel that way or you shouldn't feel that way is just not something that's going to result in that person with FTD agreeing with you. Their reality is their reality, and unfortunately you're just not going to be able to change it. Using calm, reassuring tones that generally are positive tends to work very well. Just saying no, I think this goes back to the idea of employing respectful communication is pretty important. Typically adults don't just say no to each other. Sometimes, but not all the time. So, you know, that can definitely be something. If you just say, no, you can't do that, I think most people would have a pretty strong reaction of like, why are you telling me I just can't do that? And particularly if they have no sense that they have a disease. It does require caregivers to be aware of what statements seem to work best with their person, because everybody's unique, and you may have to work at what phrases you can say to somebody with FTD that can help kind of reduce the resistance to a certain type of activity, whether it's, you know, brushing your teeth or it's going to visit somebody. Then thinking about the person's environment is also pretty important. It's, once again, it does come down to the caregivers being kind of aware of a person's environment and what their possible triggers might be. So it's thinking about like, oh, every time we go to take a shower, Joe does not want to do that. And thinking about, well, all right, let's see if we can figure out what is making him so resistant. One thing I do often say to clients is that all behavior is some type of communication for people with dementia. So if they're resisting it, they are trying to communicate something. And it could be fear, it could be anger, it could be a whole litany of things. And the caregiver is kind of playing detective and trying to figure out exactly what their behavior is trying to say to that person. Avoiding overstimulating environments, and if it's necessary to go to an overstimulating environment, seeking accommodations to kind of try to lower the chances of someone having resistant behaviors. Example is if going to the doctor is a triggering behavior, it makes them very upset and they don't want to go, they refuse to go. It may be because they don't want to sit in the waiting room for a long time, or they don't want, you know, they're concerned about looked at for other people. So maybe asking for an early doctor's appointment when there's less likely people to be around and like less likely of a long wait because the physicians aren't backed up. And then also looking for things in their life that helps a person regain calm. For some people, it might be certain types of music. It could be taking a walk. It could be a certain activity. The environmental things do need to be things that caregivers are observing with their person and, you know, using those factors to kind of help with caregiving for FTD. The last thing I'm going to talk about is medications. So like I said earlier, medication can't be used to stop the progression of FTD. Rather, medications are used to address some of the behaviors and emotional reactions for a person living with FTD. There are three classes of common psychotropic medication that are usually used with people living with FTD. I'm going to go through them. The first one is usually the acronym you may hear is SSRI, sometimes called antidepressants. They're selective serotonin reuptake inhibitors. These are used to address issues of irritability, tearfulness, depression, anxiety. They're typically used early in disease progression. They may also help with the overeating, impulsive behaviors that someone might see with FTD, but they do have some side effects, including stomach issues, nausea, and headaches. The next class is called anticonvulsants. These can serve as a mood stabilizer, and sometimes they're used by themselves or in conjunction with an antipsychotic. And then the last one is the neuropleptics, or the atypical antipsychotics. These are typically used when there's a hyper behavior going on, so hyper emotionality, hyper aggression, or severe compulsive behaviors and agitation. They're not FDA approved to treat FTD or any other types of dementias. And that's because there's a small percentage, it typically is less than 5% of the time, that usage has been shown to contribute to death from pneumonia or stroke in persons with dementia-related psychosis. So what that really boils down to is caregivers need to have a discussion with the medical team to determine if the potential benefits outweigh the risks of having the person with FTD take this class of medications. I can't say whether or not, there's no rhyme or reason of like how often these things get prescribed to people, but it is just, it's another tool in the toolbox for helping someone with FTD live their best life. The other thing I did want to also talk a little bit about is palliative care and FTD. I think people are very familiar with the concept of hospice care, which is something that usually comes into a person's life when they have less than 6 months to live. But palliative care is a specialized and individual care for people living with a serious medical condition, and FTD falls into that bucket. And the idea is increasing the quality of life and providing extra support for management of both physical and non-physical symptoms. It's something, palliative care can be pursued at diagnosis or any time after diagnosis, and the eligibility is dependent on the diagnosis. So if someone has the diagnosis of FTD, they're usually there, and a referral by a healthcare professional. Obviously, whether or not palliative care is covered depends on one's particular insurance coverage, but that's just something that's there. So what would palliative care do? They would have open discussions about goals of care, talking about treatment choices, coordination of care with new and existing healthcare providers. They provide emotional and spiritual support, and they also support the family and caregivers as it is, as it is caring for the person with FTD. And it is possible to have a medical provider that has a palliative care approach and not necessarily part of a formal palliative care team. So whether or not you would want to pursue this is really obviously up to you, but that is another, once again, another tool in the toolbox that's out there for people living with FTD to pursue if they feel that they need more support. Last topic I'm going to touch on is emergency planning. I think this is pretty important given the pandemic right now. So we here at Lifespan, we did a whole presentation on what is your plan B, and this is the idea is to giving caregivers some guidance on how to plan for an emergency where the caregiver is unable to care for the person living with dementia, in this case, living with FTD. There is a template that Lifespan put together that's available. That's something that can be sent out. But the idea is that a person, has in theory a binder or a folder or something where if an emergency happens and they have to leave the person living with dementia, everything about that's important about that person is in one place. And some things that we recommend that an emergency plan should include is contact information, details about medication management, person's daily routine, other useful information like quirks and possible behavioral triggers. If the person with FTD is going to stay in the home and somebody's coming into the home to care for them, like important information about the home, you know, how to change the setting on the temperature control, things like that. If there are pets, do they need attention? Any legal and financial information? And if there's any like longer term plans that are in place, that it might be important that's, you know, emergency caregiver may need to know about. So like I mentioned earlier, so I'm actually at the end of my talk. So these resources on the screen, the Association for Frontotemporal Degeneration, that is a national organization. They are a really great resource of various different topics around FTD. One thing I did want to talk about is they actually do have some grants for caregivers. They have a respite grant where it's a certain amount of money that will help a caregiver maybe get some needed help in the home or out of the home. They also have quality of life grants that usually focuses on the caregiver. I will say the funding is very dependent upon the organization having monies available. So I don't know where they are right now in this year in terms of giving out the respite and quality life grants, but it's something that's there. I will talk about the Finger Lakes Caregiver Institute, which is where I work. So we offer individualized care manager services, and that means, you know, if you make a referral, you can self-referral. You do not need a physician to make a referral for you. The email and the phone number are on the screen. If you call the phone, our lovely intake person, Sarah, will talk to you about what you're looking for help with and maybe connect you with a care manager. But we do meetings, in person, virtual, phone, about what's going on, who you're caring for, and how we can help you. And the last one, the Safety and Dementia website is something that I wanted to highlight because it addresses two very touchy topics. One is firearms and the other one is driving. And the way that website works is you can pick a particular topic, and then it will ask you a series of questions. For firearms, for example, it'll say, are there firearms in the home? Yes or no? Who owns the firearms? Myself, the person with dementia, and then subset questions, and then it will get you to a scenario about how to talk to the person with dementia, your concerns about that particular subject, and like what suggestions you can make in order to make the environment as safe as possible for both the person with dementia and the caregiver. So that is my talk. I have some references where I pulled up my information. I know Mara is going to send out the PowerPoint slides, so you will have those. And I'm going to open it up for questions.
Awesome. Thank you, Sue. It was a really wonderful presentation, and I really appreciate your time, and I appreciate everyone being here. We have some really good questions in the chat. So the first one is, what strategies can you recommend for caregivers when FTD person blurts out inappropriate comments, other than handing out cards that explain situations to strangers?
It's a tough one. And I think that if it's a place that you're going regularly, so say it's I'm thinking of pre-COVID, but say it's a restaurant you've been going to for a number of years, I think it's okay to have a conversation with the manager, you know, on the side at some point, saying, listen, you know, we really like coming here. We really enjoy it. We want to keep doing it, but so-and-so does have a disease, and they are going to burst out and maybe say inappropriate things. Is there something we can do? So if we come to the restaurant, can we be, you know, towards the back, a little bit away from people? I think, you know, you can't really keep you can't really do very much about, you know, if they're at the cash register and they do grab someone, beyond saying like, I'm sorry, my person is acting inappropriately, they have a disease. You know, whether or not you can bring something with them that might help them keep calm or distracted, it's very individualistic. There's no great, I hate to say it, it's all trial and error. I would say if you have the ability to have more than one person go with you to a social situation, so if you can bring someone who can maybe redirect the person with FTD while you're trying to take care of something in an office, something along those lines, you know, it's not easy. There's no great choice. There's no like excellent choice. I think it's going to be a combination of being forthright with the people who might see them more frequently, and then having some strategies available with people that you might not see very often.
Great, thank you. Yeah, that's a very nuanced answer, so I appreciate that. And it's a good question, because those cards that say, you know, my person has, you know,
Dementia usually.
Dementia, or yeah, can be helpful, but not everyone might feel comfortable using those.
Mm-hmm.
And so it sounds like having a combination of maybe conversations to the side with maybe a manager or other people, and then also what are some behavioral things that might minimize the likelihood of outbursts, which, yeah, there's no fail-proof way.
Most people, at least with the clients I work with dementia, usually know when their person tends to have a better day versus a better time of day versus a worse time of day. So if you know that your person generally does get pretty anxious and agitated in the afternoon, it's probably not the best time to run errands with them. If you can do it in the morning, when they're generally in a better mood and less likely to have some of those behavioral outbursts, that may be a better choice. But I know with FTD, it's unpredictable. I mean, you could think something is fine for 1 week and then the next week it's not, which I think is probably one of the hardest things for caregivers to work around, is like, it's so unpredictable. And that's really some of the hardest things I definitely hear people talk about. And I wish it was different.
Thank you. Another question, what other forms of treatment other than medication are typically recommended? Therapy, family therapy, etc.
I think it has a lot to do with when the person, like where in the disease progression the person is. If they are in earlier stages, I do think some of the, some family therapy can be possible. Some individual therapy can be possible. The behavioral, I mean, the communication strategies is usually the biggest tool in the toolbox. Most people say that's usually the best. Working on those communication strategies is the best. Medication is actually kind of like on the lower end of things. That's usually really to help when a person is struggling pretty badly, whether it's depression or tearfulness or that really high impulsive compulsive behavior. It's more about the communication and the environment is where people who focus on those two things tend to have the best with their person with FTD. But unfortunately, there's no way to slow progression. It is going to progress.
Okay, thank you. Do we have any other questions at this point? Okay, well, I'll give you a second if you'd like to ask any other questions. And you know, while you're thinking, Sue, do you mind going to the next slide?
Sure.
Thank you. All right, so if you found this program informative, please consider making a gift to Lifespan if you are able. We understand it's a difficult time and we just appreciate the consideration. And then I believe there's one more slide.
Yep.
If you go to the next slide, thank you. So this has some last week's and today's, but then the next coming ones. Next week, we have Healthy Living for Your Brain and Body, an upcoming caregiver education webinar, along with navigating end-of-life dementia care, addiction and Alzheimer's, and a lot more that you can find on our website. And then another thing is please answer this survey. It might be on the next slide, but I also chatted to you all the Survey Monkey link, and then you'll be getting a follow-up email, as Sue mentioned, and it'll have that as well. So your feedback is very important, and we appreciate that in advance. So I got another question privately as I was just doing the spiel. Is autopsy paid by Medicare, or does family have to private pay?
I honestly do not know. I know it doesn't automatically happen. I do think unless the person who declares the person dead requests it, I do think if it's not mandated by that person, it has to be requested by the family. But payment, I honestly don't know. I have a feeling you need to check with your insurance provider whether or not something like that would be covered. I think the exceptions could be if the person has agreed prior to their passing that they want it done. If they're participating in a research study, for example, I think that is a different scenario though. So if you're working with a neurologist and you want to ask about whether or not there are trials or studies that the person can choose to participate in after death, that's something to ask the neurologist.
Okay, thank you.
You're welcome.
All right, so thank you everyone for joining us today. We hope you have a great rest of your day, and we look forward to hopefully seeing you soon at another one of these caregiver education and wellness webinars. Thank you.
Thank you, everybody.